Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight an important paper from the November 2023 edition of the Journal of Rheumatology. Today I will be speaking with Dr. Chris Lane, who is one of the authors of an article entitled Sociocultural and Economic Disparities in Physical Therapy Utilization among insured older adults with rheumatoid arthritis. Chris, I want to thank you for taking the time to speak to me and to our listeners.
Thanks so much for having me.
And with that, we'll just go ahead with the interview, if that's okay.
Yeah, that sounds
All
good.
right. So what led to the study of to you studying the effect of social, cultural, and economic disparities in physical therapy utilization?
Yeah, that's a really great question. And I guess just to kind of back up a little bit and just talk about my interest in health
Sure.
services and disparities research, since I've kind of had a bit of a own kind of personal kind of thoughts and journey through that. So really, I started to become interested in that kind of around the pandemic time or the COVID pandemic. I'm seeing about disparities in COVID-related outcomes, people who ended up having COVID or who had worse outcomes from COVID. Really, in addition to that, hearing about structural racism and bias, such as killings from police of different individuals. So there was a lot of talk about that really in society. So really, a lot of that gave me motivation to try to figure out how we can best address a lot of these disparities that we see. I mean, especially in healthcare too. So yeah, I really started to become interested in health services and disparities research from that. And in the beginning, I was more kind of focused on really musculoskeletal kind of conditions such as knee osteoarthritis. So I did a small project on that in a couple of years ago, looking at disparities in progressive therapeutic exercise program. So that's kind of was my start in that. But then I started to transition and try to broaden my lens a little bit and see if I could apply that type of thinking towards people with other conditions too. So rheumatoid arthritis was another one I learned more about. And really, I saw that there was not a lot of research about physical therapy in particular for people with RA. But there were disparities in pain and functional outcomes for people with RA. So I think physical therapy would be a great intervention to be able to help reduce these disparities. But we need to know about the access part, if patients are getting appropriate access to PT for RA, since it is a helpful intervention. So I was looking at some previous studies on PT access and RA, and there are not a lot of studies on it. Most of the prior studies were focused on kind of self-reported data, but then I was introduced to a program through CoStar, the Center on Health Services Training and Research, and that was a summer mentoring program that was through Brown University. It was during kind of the one of the peaks of the pandemic, so I didn't get to go there personally, but still got to work with some of the staff over there, which was great, including Dr. Theresa Shireman, and they had a Medicare data set for people with RA. So really, that all kind of flowed together very well. That I could try to look at these potential disparities in PT access for people with RA.
Good, thank you. And moving on then, please, now we'll start really going into the study. And if you could review for us who you studied, number of patients, time frame, how you obtained the data, and what was the primary outcome of the study?
Okay, so yeah, so for the number of patients that we had about 106,000 older adults with RA. So these were people 65 years or older. I could talk a bit about demographics too of the sample if that kind of fits here too. But
Absolutely.
about 84% were non-Hispanic white, 9% non-Hispanic black, 7% Hispanic. The mean age was around 76 years. About three-quarters of the sample identified as female. About 23% had dual Medicare Medicaid coverage, and we used that as a proxy for lower income. So everyone in this Medicare sample had Medicare itself, but then there was a subsample that had Medicaid too, and Medicaid is often for people who have low income, although it can be also used for other situations as well. So again, about 23% had dual Medicare Medicaid coverage, which was a proxy for low income, and about 43% used DMODs, and then the mean comorbidity was about 9.8. And then talking about the time period, so that was between 2013 and 2016. So again, there was older adults, about over 65 years. Then and that was prevalent RA, and that was based on having 3 RA diagnosis codes, or at least having 2 diagnosis codes with a DMOD claim. And then dual coverage again was having that for at least 1 month out of a year. Then the Medicare data we had through the master beneficiary summary files, and that was for fee-for-service claims. And we worked with Brown University through that CoStar program. So they had a data use agreement with the Centers for Medicare and Medicaid Services. And then I think lastly, you talked about the outcome study. So our primary outcome was physical therapy utilization, and that was based on CPT codes. I mean, those are current procedural terminology codes, and that's common codes that healthcare providers use to bill for the interventions. So we used CPT codes related to physical therapy to denote physical therapy use. So for physical therapy use, it was a yes or no, whether the person used physical therapy or not. So that was with a PT evaluation code, and there was several of them. And then, so that was the rate of PT use. And then a secondary outcome was the number of PT visits. So that would be either a visit with a PT evaluation code, and then any subsequent visits with a PT related code. And then we grouped that or categorized that into low, medium, high, and very high number of visits. So either 1 to 2 for low, 3 to 8 for medium, 9 to 18 for high, and over 18 for very high.
And just a little bit, this would be during the course of the study, like not, or was it per year? Just out of curiosity.
Okay, for the PT use?
Yes.
Okay, so yeah, so that was 1 year after, so we took about 12 months after they first entered the cohort.
Okay. Why did you restrict your study to older adults with Medicare? Was it access to the data, or rather than a broad cohort?
Yeah, so I mean, so kind of for a couple of reasons too. I mean, some of the previous studies kind of had a bit of a broader range, but what really helped them most was it being a Medicare cohort itself, which actually is a kind of gives us access to a large, racially diverse, national kind of population, and of course a very large data set to begin with. So having over 100,000 patients was very helpful in being able to understand access and these potential disparities better.
Sure. Okay. So now that we've set it up, what did you find?
Okay, yeah. So one of the large results was the PT use itself. So only about 10 to 13% of the overall sample used any PT services during that time period. And in addition to that, the median number of visits was 8 to 9 in the overall sample. The breakdown was pretty spread out across the different categories, but about 10% had only 1 to 2 visits, about 30% had 3 to 8 visits, 35% had 9 to 18 visits, and about 27% had over 18 visits. And then kind of other main outcomes were the associations between race and dual coverage, and then the PT use and number of visits. And that was, and we examined that through logistic regression analyses. And I can just kind of summarize that a bit. So we adjusted for different patient characteristics like age and sex. And then we also adjusted for comorbidities and DMARD use. And those are disease-modifying antirheumatic drugs, which I didn't explain earlier. But yeah, those are common for RA. But there were no interactions between race and ethnicity and dual coverage. And that's something else that we wanted to look for too, if race and status and ethnicity and dual coverage would interact in the analyses or not. But yeah, there were no interactions with any of these outcomes. And then to talk a bit more about the odds ratios, which are common, of course, with logistic regression. So we observed that non-Hispanic Black individuals and Hispanic individuals had lower odds of PT use compared to non-Hispanic white individuals. And then adults with dual coverage, the Medicare, Medicaid, or the proxy for low income, had lower odds of PT use than adults with Medicare coverage only. So, and then we found a couple other differences too among some of the other characteristics that we looked at, such as people who use DMARDs or people who identify with female sex and those were associated with greater odds of PT use. And then people who had mobility impairments or were of old age were associated with lower odds of PT use. And then for the secondary outcome of number of PT visits, there were no differences in the distribution of PT visits across the race and ethnic groups. However, adults with dual coverage had lower odds of using more PT services compared to a lower number of visits. So really, so kind of to summarize that, then people with dual coverage or the lower income really had a fewer number of PT visits really in the sample. So that's kind of a summary of it, but I'm happy to talk about anything more out of it too.
That's perfect. That's really good. What are the implications then for the healthcare? What do you think? Where do we go?
Oh yeah, so I think there are a lot of implications, and I'll be very happy to talk about a couple of different areas, Dr. Silverman. One is that the economic disparities were large in the study. So those with dual coverage. So I mean, I didn't list out the odds ratios in specifically, but to actually do so, those with dual coverage, and there was an odds ratio of 0.44 compared to those who are non-Hispanic, Black, or Hispanic, which the odds ratios were 0.77, 0.92 specifically. So the odds ratios were particularly low for those with lower income in the study of not having not being as likely to have a PT visit. So that really does really signal to me that I think that's an area we need to focus on a lot, is on socioeconomic status and how we can improve access and what are the specific barriers there as well. Because Medicaid in particular, I mean, should theoretically give a kind of most support to a person and kind of help with financial barriers having Medicaid. But it seems like in this study, those with both Medicare and Medicaid were actually less likely to use PT and had a fewer number of visits. So that might mean that there's some other potentially socioeconomic factors or social determinants of health that we should focus on too. So some ones that kind of come into mind that I think we should think about in future research is transportation. Are people having barriers in being able to physically go to PT care? And I mean, some people could be traveling from long distances or not having a car or having a bus system to be able to work with. Even knowledge of PT services it could be important too. And I think that's both from the patient and provider side too, of patients knowing about the potential benefits of physical therapy, and physical therapists can often work with improving patients' function. But then also healthcare providers such as PTs, but then rheumatologists too, having the knowledge of the potential benefits of physical therapy can we improve referral to PT as well. Then I'd say another large implication would be structural racism or classism too. We were not able to study, structural racism or classism itself in the study, and that's something even in my own kind of research interest too, I want to study more of too, but could that be driving these disparities? And I really want to point out too that I am studying race technically in the study, but it's racism, not race, that we should really be focusing on, because race is a social construct, not a biological construct. So really looking at the social parts of race and racism, we should look at, is there maybe bias in the institutions? Are there really processes that we can maybe change? Is that affecting certain groups more than other groups as well? And structural racism itself can be a difficult kind of construct to measure. So that is always the difficulty there. That is a tough construct to measure. And people can really kind of perpetuate structural racism without actually knowing it or wanting to do it. But it can sometimes be something that just permeates through society. So certainly something I want to look at a lot more in the future. And also really just advocating more for PT use itself. And that's in addition to DMARD use. So, I mean, it's been established pretty well that DMARDs are effective for people with RA, and that's commonly prescribed for people with RA, and it can certainly help a lot with disease activity. But sometimes there can be some functional limitations too that PT could be a very good fit for. So I'm really advocating for PT as a complement to DMARD therapy. It would be very helpful as well.
It would be interesting to see if your findings are also access to care, to professional health, all professional health care. Okay, in RA, I mean, there's a lot of literature supporting that. Look, people of lower socioeconomic class, even in Canada, where it's universal health care, there are discrepancies of access to care in people of lower socioeconomic. So it strikes me is be fascinating if it were out of proportion to access to general care, because you brought up the point that, I would assume, but it's an assumption, that people who have access to rheumatologists, maybe they don't, maybe that's part of it, but rheumatologists do appreciate the idea, speaking as a rheumatologist, of importance of physiotherapy. And number two is that why would a rheumatologist, unless structural racism or some other concept comes in, not refer it to people of lower socioeconomic status if Medicare, Medicaid pays for it, if money is not the object? Interesting questions, purely hypothesis out there to think of.
Yeah, that's something we'll definitely happy to look more into. Kind of, is even the referral process is
Yeah.
there differences there, and I haven't seen any research, at least related to RA, about the referral part of it.
Yeah, I mean, I think if you have that data set, you could look at rheumatologist visits by the codings in the same cohort.
Yes, I think that'd be very interesting.
Yeah. So moving along, I mean, as I always say when I speak to people, a good study always leads to even more studies. And this certainly does fit into that. So is there any evidence that similar findings in the literature or other age groups or other insurance coverage? Because, as you are under 65, I guess there is no Medicare, but there still is Medicaid possible. Otherwise, you're stuck with private insurance or paying out of pocket or some other such thing.
Talking about, I guess, some previous research, I'm not really aware of other studies that looked at or compared PT use by race and ethnicity for people with RA. So I think that piece I just have not seen.
Right.
But socioeconomically, I did see a couple of studies that kind of fits towards this theme, although there are differences. One study did look at like education and social networks, and also having disability insurance. Could those be like predictors of PT use? And did find that those three measures were predictors of PT use. And this was by Iverson et al. And that was a self-reported. They used self-reported data, and they actually would use predominantly white individuals were involved in the study. I think about 98%. So unfortunately, not quite maybe like the racial kind of diversity of the United States population, but certainly a good study looking at socioeconomic status measures. There was another one that looked at education level, and they saw that the low education level was associated with lower allied health use. So kind of looking at allied health services more in general. And also it was associated with worse health outcomes as well. So that was a study done about 20 years ago by Jacoby et al. And then one other study too that also fits here a bit, even though they didn't look at physical therapy use, but did look more at like rheumatology, like outpatient visits, for example, and looked at DMARD use too. That was by Safardi et al. And they reported that older adults with RA and also to do Medicare and Medicaid coverage, they had fewer outpatient visits, fewer DMARD prescriptions, and worse functional outcomes than older adults with RA and Medicare only. And then, so really all three of these studies did use self-reported data. So with, our study here, we were able to use kind of the bigger kind of Medicare data set too. So I really think these studies can kind of complement in different ways. But yes, I really hopeful and want to also be involved in more research going forward and looking at these potential disparities and how we can address them.
I think it's very important. I think, disparities in healthcare is worldwide. It really is. And I think it's something we need to address to get at social ills in our society. Anything you'd like to add that maybe we missed that you think the audience would be interested in?
Yes, and I guess I see my last point about addressing disparities too. Yeah, I think we are seeing common disparities very commonly in health outcomes, and in a way, we also should pivot towards trying to address them as well. Since we have looked at these, and it's good to quantify and really know how to what stands out in these disparities. But then the next piece is to address them, and that's not something I have an immediate answers on, but something that I really want to keep working with throughout my career, because this is really my main motivation, is to help improve access and help reduce these disparities and outcomes. So that made, like, from the RA model, could look at how we can better improve either the referral or the actual use of services. Is there maybe more communication between healthcare providers, which I think that could always be improved anyway, because I really think interdisciplinary care is very helpful to achieve. But I mean, are there other more societal type factors that we can look at, some of those social determinants of health? I think that's where we do need to start thinking about more, and probably working with other people from other disciplines too. I mean, maybe sociologists, psychologists. There's so many other factors. Haven't even talked about mental health, but a lot of psychological factors too that we could certainly talk about and try to address as well. So in a way, I think it is just kind of a lot of us coming together to see how we can kind of tackle these issues together.
That's great.
And then I guess one other point, which is more about the examination really, but really I think just improving how we collect a lot of this patient data too. So like race and ethnicity, for example, or some of these socioeconomic status variables. I mean, the Medicare data set is great too, but it's still always limitations in how a lot of these socio-demographic factors are actually maybe either inputted or how they're collected in the health system. So trying to find more accurate data, which would be helpful. And yeah, how can we maybe better even measure like structural racism too? Because I mean, one thing would be like segregation in history had led to kind of changes in resources, and which actually reminds me of one other thing that I found a very helpful term that was used by Hubert et al. About PT or physical therapy deserts too. Could there be physical therapy deserts like there are food deserts, just places, areas that don't have as many PT services than other places? So I think there's just so many fascinating areas to think about, but really these disparities are very critical to address.
Thank you. So this is my ignorance of how the data is reported. When you talk about Hispanic, non-Hispanic, white, non-Hispanic, Black, is it self-reported or physician-reported? Who fills it out?
Yeah, so that's a really good question, because that's actually part of why I think the process is sometimes inconsistent too, because in the health system, most of the time it should be the patient that fills it out, but I feel like sometimes the physician might fill it out as well. And I guess I'll talk about it just an end of one. That's my own personal for me. But I think I was listed as different races than what I would identify as. I feel like on different kind of forms too. So I think it is pretty inconsistent how the race and ethnicity data can be filled out really in these systems.
Yeah, it's really interesting as a Canadian that there are only three choices and how it's defined. But anyway, that's for another day. And I want to thank you, Dr. Lane, for taking the time to review the findings of the paper and its implications. To our viewers and listeners, please read the entire manuscript entitled Social, Cultural, and Economic Disparities in Physical Therapy Utilization among insured or adults with rheumatoid arthritis. And there's an accompanying editorial I direct you to titled Unequal Treatment, Physical Therapy Utilization in Rheumatoid Arthritis. by Dr. Jennifer Barton from the Oregon Health and Science University and the VA Portland Healthcare System, Portland, Oregon, USA, to help you get a better understanding of how social and economic disparities do alter the health of patients and what may need to become to overcome these disparities to improve the health of all patients with RA, and I would suggest all illnesses. Both of these articles are now available on the journal's website, and they will appear in the November print edition of the journal. And I want to thank both my guests and the audience for joining us, and hope you will join us next month when I'll speak to the author of an article of particular interest that I've selected from the December 2023 edition. I'd love to hear your comments on X, formerly known as Twitter. So it's X at JRoom, or by email manuscripts@jroom.com. Thank you.